nevertheless, because some of my colleagues also asked for this. It's weird, I know. Okay. Yeah. So in the recording, I discussed the MSK related questions, and I want to stress on that it was actually quite. I didn't realize that it would take that much time. But I don't think it will go to waste, because even in our OSPE we got like 3 or 4 farm questions, and 2 questions were just from MSK, and also since Shiranti Madam has done quite a lot from MSK. I believe that you will also get at least 2 questions from that out of 4 or 5 that you will get. And when you go through the other modules, there's not much things to ask in OSPEs. There's definitely a lot to ask in MCQs, but OSPE wise, let's see. I don't know that they, unless they ask some very weird questions, they don't have that many high yield questions to ask from, especially like except for antibiotics. IPD is basically useless for OSPE. Neuro, there's no point of asking you right now, because these again come back in a higher scope in next years. Anyhow, we'll start. So we'll first do the neuro. I think I sent you the PDFs a little while ago, like few hours ago. Hope you got time to read through it. But nevertheless, I'll read the questions with you. And I personally have a complaint that when I'm reading questions, I omit a lot of things, because there's a way that I read. I just focus on the key points. If it's like bothering you guys, let me know. The first question. A 19-year-old rugby player after an accidental injury. Also, you can ask any question at any time. Both my phone and the Zoom chat is here. Yeah. So, a rugby player after accidental injury was admitted to NHSL, where they found he was having macrocytic anemia, apart from the injury, of course, where he was prescribed a drug named carbovit with folate. So, carbovit is B12 complex, actually, oral B12 complex. He has taken the drug for around 2 weeks, where he developed fever with erythematous rash and later collapsed and died due to sepsis. Later found out he was given an anti-seizure medication due to a prescription error. What would have been the anti-seizure drug that was given? So this is a very classic look-alike, sound-alike, not look-alike, but sound-alike drugs that go misplaced in prescriptions. What do you think? So what is the complication? Okay, let's go to the second question. What would have been the specific complication that has occurred? Had gotten fever with erythematous rash and then died due to sepsis. Anyone has any guesses? Yeah, I'm not receiving any, so I'll move on. So this is, I think I discussed a similar question in the MSK bat also. This is again Stevens-Johnson syndrome. So Stevens-Johnson syndrome, I told you it's a spectrum. So for in the closer end you have the what you call erythema multiforme. That's a rash where you have sort of a target lesion where there's a red color ring with a red color dot in the middle, and the rest of the skin looks normal. And then when it progresses to SJS, what happens is you get you start getting oral and mucosal ulcers, along with your rash becomes widespread, and also your skin starts to desquamate, like it starts to like rip off. So when it's involving less than 10% of your skin, we call it SJS. Stevens-Johnson, if it involves more than 30%, we call it TENS. Toxic epidermal necrolysis. Epidermal necrolysis. Epidermis එක ගැඩිලා necrosal යනවා. So what is the anti-seizure medication that happens? And also there's actually 2 anti-seizure medication that commonly occurs. So they are saying that this is a prescription error, right? So what is a sound-alike drug for, obviously not folate, but for carbovit? It's carbamazepine. Okay, so the anti-seizure medication that they would have given was carbamazepine, and the specific complication was he must have gone either SJS or TENS, which has later developed. So the reason that it's fatal is that you lose your skin, so your physical barrier, and then later on you are exposed to a lot of infections and stuff, so you get sepsis and you die, or you go into hypovolemia like in burns, because you lose a lot of water from your skin. But this is sepsis. So the complication that has occurred was sepsis due to secondary to SJS. State 2 other drugs that would cause similar reaction. So like I said, there's another anticonvulsant that's known to give this, that is lamotrigine. Okay, so lamotrigine is a drug that doesn't have that many side effects. So, and at least in the papers, it doesn't have that many side effects. The only thing that they usually ask is SJs, so it can cause SJs. And there's a buttload of drugs that can cause Steven Johnson. Like in MSK, we discuss about allopurinol. That is another common drug that causes this. And also in antibiotics, you might find few others. Uh, what like sulfonamide drugs, macrolides can cause SJs. Even ampicillin can cause SJs. So there's quite a bit of drugs. You can write two of them. High yield ones are carbamazepine, lamivudine, allopurinol, those, and sulfonamides also little high yield. What would be the management in such a situation? So, and I'm sorry when I'm referring not to MSK that because it's supposed to be a continuum. But however, I told you in that how to write an answer for something that you have never come across like this, like a prescription error or something, especially in emergency situation. So, obviously you don't know how to manage SJs, no? So, the way that you're supposed to write is if it is due to a drug or if it is due to some cause, the first thing you're supposed to do is stop the cause. So in this case, stop the drug. I know that he must not be taking the drug right now, but you say it. Stop the drug or decontinue the drug or something like that. And then second step, always, you might not have learned this right now, but you will definitely learn it clinical sciences and you continue to use it until your death. That is called ABC management. Yeah, otherwise ATLS protocol or something like that. So that is ABC is A for airway. And the first thing you do is you make sure the patient's airway is pairing. Why? You don't breathe, you die within seconds. So කට ඇරලා බලනවා if there's any secretions and if there's anything clogging the airway, you take it out. අනේ English අවුල්ලන් කියන්න සිංහලෙන් කියන්න. Yeah, so first you make sure the airway is pairing. So that is A. B is breathing. You make sure their breathing is okay. You auscultate and see if there's any problem, if they have developed any pneumothorax or hemothorax, something like that. So it's not obviously apply to this situation, but මේ මේක මේ කෝකටත් අයිල මේ ආන්සර් එකක් කියන්නේ. Okay, so you make sure ABC is okay. So B is breathing, C is their circulation. So in that you check the blood pressure, you check the heart rate. If there is like a hypovolemic situation where your blood pressure is dropping and heart rate is going up, you make sure to give some fluid, like IV fluid. That doesn't matter how much and how to give වැඩක් නෑ. You give some fluid. ලේ මදින ලේ එකක් දෙනවා. Fluid වලට වඩා ලේ is better actually. So you do that. So you stop the drug, then ABC management. And ඒක කළාට පස්සේ මේ then only you come into this what do you call the specific management. Okay, so in this case, so SJS technically doesn't have any specific management. You may make sure that make a what do you call it, like there's no specific antidote as such for SJS. So what you can do is they say there's a little bit of controversy behind whether you can use hydrocortisone or anti-inflammatory drug. Yes, if you want, you can give like IV hydrocortisone dose because SJS in technically it's a non-allergic immune-mediated reaction. So you can give some IV hydrocortisone along with that you do the sepsis management. So you write that. You don't have to write how to manage the sepsis. Right, I would manage the sepsis situation. That's it. And that if you write that much, if you have time to write that much, if they don't give the mask, ask them to take it home. So that is good enough. And that particular thing that I'm talking about, how to write an answer, I added a slide in the MSK PDF. So go and take a look there. And if it's not clear, ask me again. Then suggest methods to minimize such prescription errors. So obviously thing over make sure your handwriting is clear. Make sure to write generic names. So carbovitis, I think it's a companion name. So otherwise B12 complex is generic name. So make sure to write it in generic names, clear handwriting, write the indication why you are the macrocytic anemia එකට දුන්නා කිව්වා මේ pharmacy එකෙන් carbamazepine දෙන්නේ නැහනේ. So write the indication, or write something. Okay? Unfortunately, this is an actual situation. This actual incident that occurred, I think in 2010 or something. This was it's a boy from my school, and I remember when I was like in I heard this news, and also when I came to faculty, also someone told me this, like in a lecture. That came to my mind, but yeah, actually he died because of carbamazepine given to him in the NHSL accident service department. Yeah. So because I couldn't, I mean, there's not many things to ask in OSPEs related to what do you call anticonvulsant. So I tried to summarize the most high yield stuff that they can ask, at least in MCQs. So sodium valproate, you know that it's a broad spectrum one, right? It has GABA, sodium, chloride, or okkoma channels වලින් block කරලා යනවනේ. So because it has broad spectrum, basically you can use it for anything. What they say is if you don't know what it is, use it again. So the common side effects they ask is it has weight gain effect. Weight gain, you know, and also they say it can cause alopecia. Alopecia කොණ්ඩේ හැරිලා අලුතෙන් එන hair එක they say it's curly කියලා පොඩක් curly. And also PCOS, polycystic ovarian syndrome කියලා එකක් තියෙනවා. So ඒකෙදි you get weight gain, acne, so those stuff also happens. Then systemically it can cause hepatitis, pancreatitis. And this is another very high yield question that they ask in MCQ, thrombocytopenia. The reason is polyamide sodium valproate දෙනවා, and then they come with fever. What is the first DD you are supposed to consider when the child come with fever or adult even? Dengue. So dengue also causes thrombocytopenia. So if the patient is already on sodium valproate, පොඩි අවුලක් එනවා අර මේ platelet count වල. ඔය හිතා ගන්න බෑ මේක dengue හින්දාද අර sodium valproate. So because of that you have to keep this in mind, thrombocytopenia. Yeah. So remember that this has weight gain also. That's also very high yield. So carbamazepine, what they say is you can use it except in absence and myoclonic. So you have basically 4 types of fever, seizures. Okay, for your level, just remember like 4 types. You have generalized seizures where your whole body, not whole body, but more than one part of your body is involved. So that is generalized seizure. Focal seizures is when you're one part of your body, like එකක් ගහනවා, එක කකුලක් ගහනවා, something like that. Focal. Then absence seizures is you don't have the convulsion part. I hope you know the difference between seizure, convulsion, and epilepsy. So seizure is the electric part that happens in our head. Convulsion is ගැහෙනවා නම් that's a convulsion. Epilepsy is, of course, it's a diagnosis of a syndrome. It's a diagnosis. So absence එකේ convulsion එක නෑ, ඒක නම් absent වෙලා යන එක. වාට වෙනින් ඇස් පිල්ලම් ගහන්නද ඔහේ බලන් ඉන්නවා, ඒක වෙන ලෝකයකට යනවා, and then within seconds they come back and they don't remember the part where they were absent. That's absence. Myoclonic seizures is jerks. ඕක මේ usually එන්නේ උදේ පාන්දර මේ තේක අතේ අරන් තේක බොන්න යනකොට තේක ගිහලා ගන්න එක. ඒක පාට වත ගැස්ස. That's myoclonic. So you don't use this carbamazepine in absence and myoclonic. Otherwise you can use it in focal and generalized. Very good drug actually. Somewhat good drug. The common question they ask is it can cause SJS, TENS, and also it has a photosensitivity rash. Then it can cause diplopia, not very high yield, but SIADH they ask sometimes because it can cause hyponatry. Yeah. Then lamotrigine, I told you already, it has SJS and TENS. Otherwise, it's a good drug, doesn't have that many side effects. Levetiracetam is actually the best drug out of all because it has virtually no side effects. They say sometimes you can get mood changes and irritability, but that's because it's the only side effect that it has. And it's a very good drug because you have IV preparation of this also. Sodium valproate, carbamazepine, lamotrigine, I'm not sure, but there's no IV preparation. So you can't use it in emergency situation. Emergency the IV දෙන්න එපා. So levetiracetam has IV prep, so you can give it. Topiramate, you might have come across this. අපි මේ lecture එක කරන කාලේ මේක තිබ්බේ නෑ in the lecture note. But I added this because this has weight loss effect which quite often comes in MCQs. The reason they say make a weight gain එකක් තියෙනවානේ. So if you are mixing 2 drugs, you can mix it sodium valproate and topiramate, so it balance it off the weight gain and weight loss effect. So that's actually a thing that we do in LRH. එදි තමයි මට ඔක්කේ කවුරු register කරන කර කවුරු. Then I mean this question I came across a lot in papers, but then I got context to it afterwards. Vigabatrin, of course, not a very high yield drug because the only indication it has is that syndrome called infantile spasm. West syndrome කියලා තියෙන අහලා ඇති සමහර විට. West syndrome එකෙත් if you have West syndrome with tuberous sclerosis කියලා තව ලෙඩක් ඔය දෙකම වෙනකොට තමයි Vigabatrin දෙන්නේ. Otherwise West syndrome එකට දෙන්නේ ACTH කියලා drug. You know ACTH අර common එකකුත්. But then this side effects quite often comes in MCQs. At least not in your level. Our level peripheral visual field effect. They get sort of a tunnel vision after. Phenytoin, of course, can come in your MCQs. So phenytoin no longer used as oral because of its lot of side effects and also zero order kinetics. The first order and zero order. So zero order තිබ්බම හරි අමාරුයි dose adjustments කරන්න. So එහෙනම් වැඩිය දෙන්නේ නැහැ. But still we use the IV prep in status epilepticus. So seizures වල එන මේ emergency එක තමයි status epilepticus. ඒ කියන්නේ ඌ යනවා seizure state එක. Where it's not resolving. කියන්නේ අපේ brain එක හැදිලා තියෙන්නේ ඕම පිස්සු කෙරුනම ඒකේ automatically inhibitory mechanisms තියෙනවා seizure එක නවත්තන්න. seizure එක කියන්නේ ඔළුව පිස්සු කෙරෙනවා. So ඒක නවත්තන්න inhibitory mechanism තියෙනවා. ඒක උන් නැති වුනම you go into status where you are seizing uncontrollably නවතින්නේ නැති. So ඒක තමයි seizures වල තියෙන emergency එක. So ඒකෙදී there's a place for phenytoin, not first line, but there's a place for phenytoin. That's the only place we use it commonly. We use it commonly there. So phenytoin, otherwise, if you use it for long term, you get cosmetic side effects. Hirsutism, gum hypertrophy, කැත කැත ඒවා ටිකක් එනවා. කැත වෙනවා. හරි කැත වෙනවා නම් it's true කියලා ගන්න. But IV use කරනකොට එන ලොකු side effect එක which we have to know, must know එක තමයි arrhythmia. It can cause arrhythmia. So when you are giving IV phenytoin, you have to connect the patient to ECG monitor. Must thing. එනේ නැත්තම් එක්ක patient මරනවා එක්ක මරනවා. Then phenobarbital similarly, not a quite common drug to use in oral, but IV එක against status epilepticus වල දෙනවා. That phenytoin and phenobarbital you can give either. phenytoin no phenobarbital. So ඒකේ ප්‍රශ්නේ ඉන්නේ අරයාගේ arrhythmias යනවා මෙයාගේ respiratory depression යනවා. So මෙයාගේ දෙනකොට you have to keep the ambu bag nearby. So this අර අය phenytoin දෙනවා නම් keep the ECG monitor මේක නම් ambu bag because the depression ගියොත් එහෙම you have to ventilate. Then benzodiazepine of course you use it in against status epilepticus. AK you have lot of preparations. I'm මෙතන මම ලියලා තියෙන lorazepam diazepam විතරයි. තව midazolam කියලා තව එකක් තියෙනවා. And there's a lot more. Lorazepam of course is the IV prep. Best drug out of the benzodiazepine in status, but that also has respiratory depression, hypertension, and diazepam අහන්න පුළුවන් because it has a rectal preparation. I'll come to that. I'll discuss the emergency management of status. The reason I put this is definitely not for your level, but because they ask these sort of management questions, good to have some sort of idea, okay? Because you definitely must have seen this in I probably not, but LRH එකේ බකින්න අවශ්‍යම එකක් මේක. So when a patient comes with status කියන්නේ මේ කියන්නේ if it is between less than 5 minutes of seizure, you don't have to worry much about it because it usually මං කිව්වා වගේ negate මේ inhibitory mechanisms වලින් it stops it on your own. So A level එකේ if you like ගෙදර මිනිස්සෙක් සීසනවා කියන නැත්නම් ඉස්කෝලේ එකේ හරි කවුරු යාළුවෙක් සීසනවා කියන so what you have to do is put them into left lateral posture. උඩ බලන් ඉන්න එපා because they can aspirate. අර කටින් එනවනේ සෙමනම්මන. So other than that you make sure their ABC is paid. යාවේ breathing circulation. So යාවේ එකේ especially අර මොන හරි secretion කෙල මොන හරි එනවනම් suck it out. එළියට ගන්න එක. මම දැන් suck කරන්න එකක් නැත්නම් ලේන්සුවක් අතේ වැදලි වල මේ good thing to know the first time I may witnessed a seizure was when I was in my western music period. It's cool, yeah. It was quite scary about it. Of course I didn't do any of this shit, but yeah, so make sure to suck the secretions out, just put it in and take the stuff out. But if you have oxygen, give oxygen. Those are the important steps you can do as emergency management. Then අනිත් you don't have to remember attached to pulse oximetry, ECG, BP ටික කරලා තියාගන්න ඕනේ මේ වෙලාවේ because now if it prolongs then you have other management with the medicated kind. Then ඊළඟ point එක get IV access if possible. So that is why benzodiazepine comes in different preps and it's important to know all the preps because season එකේට IV access නිකන් ගහන්නත් බෑනේ කට මේ cannula එක so season එනකොට කොහොමද ගහන්නේ right ගහන අය ඉන්නවා nurses ලාට can but if you can't that then the rectal diazepam and stuff comes into play because IV දෙන්න බැරි හින්දා. So if you have IV access, if the status go beyond now status එකේ definition එකෙන්ම තියෙන්නේ more than 5 minutes seizure එකක් තමයි status කියන්නේ. So 5 minutes පන්නර පස්ස තමයි ඔන්න you are start giving drugs. So එතකොට if you have the IV access you can give IV lorazepam. So if they ask like a situation and dealer what's the drug of choice or something, First drug of choice is lorazepam or a benzodiazepine. So if you can't give IV, then you can go for IM midazolam or rectal diazepam or something. Then we still prolong. Then IV lorazepam එකක් නෙමෙයි දෙන්න actually මේකේ dosing මේකක් තියෙනවා. You can repeat it twice. Don't have to know. Then but if it still continues, that means you can't control it with diazepams. Then you go for big guns. You can go for IV phenytoin. Make sure patient attached with ECG, or you can go to IV phenobarb and make sure the ambu bag is there. So but the best drug is actually IV levetiracetam, which we sometimes have, sometimes don't. I think ඒක reliable නැති හින්දා because of the price, of course. මේ අර දෙක තමයි what they usually ask. And if it still goes beyond that thing, that means you can't control the seizure, usually due to some structural defect hari tumor එකක් hari හින්දා. එතකොට ඉතින් you give propofol and intubate and patient ICU ගෙනියන්න. can be anesthetize කරලා ICU ගෙනියන එක තමයි කරන්නේ. Okay. If I hope you have any, if you have any questions, you can ask. So if I don't have any questions. Okay. Next question. If යාරක මම unclear එකක් තිබ්බොත් කියන්න. In order for the suturing of a scalp laceration, local infiltration of an anesthetic was given. During the suturing, patient complained a metallic taste in mouth. With perioral tingling sensation, within minutes he developed a generalized seizure. Identify the cause and mention expected further complication if not managed. So what's the cause? I hope you know this because we had a lecture called Neurology Pearls. I don't know whether you had it. Yeah, we had a lecture called Neurology Pearls where ඔක්කොම departments වලින් ඇවිල්ලා මගුලක් කළා. ඔන්න ඕකේ කරු pearl එකක් මේක. This is in fact, if you know the answer, put it in the chat. මම නිකන් හරි බලන්න ජොලිය. Yeah, so this is what you call local anesthetic poisoning, lignocaine poisoning or lignocaine toxicity. So you talk about a bunch about how lignocaine can go into system and then it can cause side effects. So this is that. If it goes into the systemic circulation, it can cause. So this is how you identify it. So ඒකේ තියෙනවා early features and late features and එහෙම කියලා තියෙනවා. So early features you get is this metallic taste. නිකන් කට ඇතුලේ නිකන් ජකඩයක් දාලා වගේ taste එකක් and perioral numbness එකක්. Sometimes it feels like tingling sense. So ඒ ටික ඇවිල්ලා then the early පොඩ්ඩක් serious feature they get is they go into a seizure. All these are early features. They go into a seizure. So they say in lignocaine, CNS manifestations comes early. And then later on you get CVS manifestations. Then you get hypertension, bradycardia, and then you go into respiratory depression, and then you die. Of course, beyond. So this is very important to know because you have to identify it in this state and manage. Okay, so identify the causes. This is local anesthetic toxicity or lignocaine toxicity. Mention expected further complications. So meet a paucity and CVS. Now they are going into hypertension and, like I said, respiratory depression and stuff. So you have to know the maximum dose of the medicine. So this is a must know thing forever and never, sort of. You have two preps, no? You have lignocaine and you have lignocaine plus adrenaline, right? I hope you know the reason because I ask it later. So the maximum doses you have to know for both. Lignocaine, just lignocaine, the maximum dose is 3 milliliters per kg. 3 milliliters per kg. Some people say 3 to 5, but 3 කියලා ගන්නවා. Then for lignocaine with adrenaline it's 7. So there's a big gap. So that's why adrenaline දුන්නම, so one of the advantages is you can give a high dose. So 7 milligrams per kg. So that is a dose. So මේක දැන් picture එකේ දාලා තියෙන්නේ lignocaine with adrenaline, and in scalp laceration it's good to use lignocaine with adrenaline if you know your anatomy. Remember, scalp has profuse blood supply and naked blood vessels are kept open with what do you call it, for neurosis or something. So because of that, it's better to give adrenaline because it also constricts the vessel. Because lignocaine itself has vasodilate reaction actually. So yeah. Maximum dose is 7 milligrams per kg. Laceration using lignocaine with adrenaline. If the patient was 50 kg, calculate the maximum dose to be given. ඔය calculation එකකින් කරන්න පුළුවන් දාගෙන අර 7 වැඩි කිරීම kg 50 and then මේක 2% නේ 2% වලට බලලා එහෙම බම්බුවක් කරන් තියෙනවා. ඒක කරන්න ඉතින්. ඒක මොකද එකපාරක් OSPE එක අහලා තිබ්බා. Then how to make sure you aren't injecting to a vein during infection. So those stuff are clinical. So you are supposed to know how හැමදාම කරනවානේ lignocaine ගහන්න කලින් බලන්න ඕනේ vein එක දින්නේ කියලා. Because otherwise you are කෙලින්ම giving it to the system. So what do? You put the needle in and then you aspirate a little bit, right? And you see whether the blood is coming. If the blood is coming, that means you are in a vein. You aspirate the needle and see whether the blood is coming. If not, you can safely infiltrate. Because infiltration කියන්නේ vessel එකකට ගහනවා නෙවෙයි. හරිද? එන වටේට මොකක් හරි වා scalp එකේ laceration එක වටේට තමයි ගහන්නේ. So you can suture it. You're not giving it to the blood vessel. Then list 3 advantages of lignocaine with adrenaline over just lignocaine. So that is why I asked that. So yeah, so one is, now I already told you, you can give a higher dose. Because why? Adrenaline causes vasoconstriction. So in the system එකට යනවා අඩුයි. Right, ඒ වටේ තියලා නිකන් පොඩි local effect එකක් තමයි දෙන්නේ. So it's good. So you can give higher dose. And then you can give 3 කියන්න බෑ. හිතන්න බෑ තුනක්. දාන්න බාන්නේ මොකක් හරි එකක් chat එකට පුළුවන්. Of course it has less side effects. අනිත් එක මේ it stays for long. The onset නෙමෙයි, the duration of action is prolonged. Because ඒක යනවා අඩුයිනේ මේ system එකට system run එක අඩු හින්දා it stays there for long. So duration of action is prolonged. You can give a higher dose and also systemic side effects are less. Alright. Which pain fibers are blocked with local anesthesia? So sometimes they can ask this. So the pain fibers are A delta and C fibers. Okay, first block when C fibers and then later on A delta fibers, but they can make a part of a block. So those are the pain fibers. And also another thing that you're supposed to know is along with that temperature fibers also get affected. Again, it will not block. Okay, තියෙනවා පිළිවෙලක්. හරිද? මුලින්ම sympathetic block වෙනවා and then temperature block වෙනවා, pain block වෙනවා. මොම ගිහලා අන්තිමට තමයි motor block වෙන්නේ. Why it's important කියලා if you notice මේ ඔය block එක කළාට පස්සේ අහන්නේ anesthetic මෙතන රිදෙනවාද කියලා. So රිදෙන එක කිව්වේ නැත්නම් මොකද කරන්නේ? අර මේ වතුර එක අරන් ඉවරලා ඇඟට දාලා ඉවරලා අහනවා. එක්ක මොකක් හරි මේ hand sanitizer එකක් ඇඟට දාලා හරිනවා. සීතල දැනෙනවද? Yeah. So that is because temperature fibers get blocked. It also කියන කකුල උස්සන්න, අත උස්සන්න, අත වැඩ that to see whether the motor fibers are blocked. So if the temperature fibers are blocked, you can reliably say මෙයාගේ pain එකක් ගිහිල්ලා ඇති කියලා. So remember that. Okay. Then okay, first identify the pictures. So make a question එක දාන්න අමතක කරලා. So what I'm asking is match the bottle with the indication. Or yeah. So පළවෙනි එකේ ඒකේ තියෙන්නේ lignocaine with adrenaline. දෙවෙනි එකේ තියෙන්නේ bupivacaine. I hope you can identify this. Now මම මේ කියන හින්දා ඉතින් it's easy. C is lignocaine. So just lignocaine. Or you can call it xylocaine also. Then D is what? Bupivacaine and dextrose. Bupivacaine hydrochloride in dextrose injection. E is ketamine. G is ethomidate. F එක මම දීලා නැහැ. I hope you know what this is. I'm not going to say it. I'm not going to say it. If you can, put it in the chat. Okay. So spinal anesthesia for a hernia repair. So spinal වල මොකක්ද දෙන්නේ? I hope you know that there's no way I can explain all 5. Why you can't give the others? I can only tell what is the most suitable. So spinal wala, if you have noticed, what you give is bupivacaine. But is it so B? The bupivacaine දෙකක් තියෙනවානේ B and D කියලා. Which one do you give? Well, I think yeah, so then bupivacaine with dextrose. Okay, it's called, you might have heard it, heavy marking. Okay, give me 1 minute. Okay, wait. Okay, sorry about that. I hope I'm still audible. Okay, what was I saying? Yeah, spinal line. So yeah, you give bupivacaine, bupivacaine with dextrose. You might have heard this called heavy marking. Heavy marking, then why is it called heavy? And the reason you put dextrose is to make it heavy. So spinal wala you want it to descend down because if it ascends, what happens? You get respiratory. Then L2 L1 හරියනේ. ඔක උඩට ගියොත් එහෙම T වලට ගියොත් එහෙම යා intercostal block වෙනවා මුලින් ඊට පස්සේ තව උඩට ගියොත් එහෙම diaphragm එකකින් block වෙන C වලට යන්න ඕනේ. But එහෙම ගිහලා you get respiratory depression, so that's a problem. So you want it to descend down. ඒක තමයි අර මේ මොකද්ද ස්පයිනල් ඩීලේ වල ටික වෙලාවක් ඉඳගෙන ඉන්න කියලා and then ඇදටත් දාලා ඇද පොඩ්ඩක් angle කරන්න. You keep it in like 30-degree angle, so you want it to descend down. So that's why you put dextrose to make it heavy. So you can write, so the answer is D. For spinal anesthesia, what you give is bupivacaine with dextrose, not just bupivacaine. There are instances you give just with bupivacaine. That's why I said hernia repair here. But you don't have to know that, okay? They know, okay, I'll tell you. If you do like surgeries in epigastric area, sometimes you just give bupivacaine because you need it to ascend a little bit, but that's for the dangerous. I thought some people prefer to just give general anesthesia. So no, not for you. Okay, ear laceration. So ear laceration, of course, usually if it's a laceration, you can just do it with local anesthesia. So what any preferred one is usually lignocaine, right? But the reason I put ear is, I hope you know this by now, you can't give lignocaine with adrenaline here. Why? Ear has end arterial supply. So you have to know the places where you have end arterial supply. Where ear එක, nose එක, and then finger digits. Digital laceration you can't get. And then also penis. So those places where you have end arteries, you can't give adrenaline because it causes vasoconstriction and goes into gangrene. So you give lignocaine, just lignocaine. So the answer is C. Limb amputation after a landmine injury. So I want you to imagine a landmine so you can't stop the bleeding, and of course it's bleeding, and you want to amputate the limb because like it's hard, so you want to amputate and make like a surgical incision, and it's easy to control the bleeding. So in that case, what do you give? Hope you know this. It's ketamine. It's a general anesthesia. The ketamine is not usually used anymore. Or use kind of situation if you have what you call it, hemodynamic instability, because if you go into and look in the ketamine action, it causes increased heart rate and increase in blood pressure, and also it increases the respiratory rate also. So it's good no, because bleed and got a hypertension in, so this helps you to keep the hemodynamic stability. So in those situations you give ketamine in sort of situation. Large infected sebaceous cyst in face. So sebaceous cyst කියන්නේ මොකක්ද කියලා දන්නවා කියලා I hope you know guys. It's just like a small lump examination වලට ගන්න එකන්නේ. Where you have the punctum. Sebaceous cyst එකේ characteristic feature is the punctum. Yeah, so sebaceous cyst usually you don't have to like anesthetize the patient. You can give it, you can do it with local anesthetics. So this is a very tricky question. But now what I've said is large cock and it's infected. The infected sebaceous cysts are there. Normally it's not infected, but it can get infected in the face also. So now there's a problem. Okay, this is little too hard for you. This is little too hard for me also. It's just I know this. I'll tell you why. Okay, so in this case, actually, you can't do this with local anesthetics. What I want you to learn from this is not about sebaceous, is when you have an infected or an inflammatory sort of a lesion, you can't give lignocaine. හරිද? ඕක කියලා ඇති lecture note එක අනිවාර්යෙන්. Because you talk about PKs, right? How lignocaine dissociates in the tissue and then it may goes something like that. So when the tissue is infected, it's acidic. That's acidic environment there. So when it's acidic, that dissociation doesn't happen. So the lignocaine doesn't give the anesthesia effect. So it doesn't get, you don't get the pain relief. If you try to operate on this with just lignocaine, is going to be in a lot of pain. And also this is in face also. Face again, there's a little bit of problem using lignocaine. Now you can use lignocaine, no problem. You can use lignocaine with adrenaline. එහෙම එකක් තියෙනවා. එතනත් පොඩි controversy එකක් තියෙනවා. It's just nose and ear කියලා. Just don't think about it. But yeah, infected tissue වල basically or inflamed tissue වල it's hard to use lignocaine. So instead you need a local එකකට වඩා පොඩි widespread effect එකක් තියෙන එකක්. So in this case, if at least if you write all the answers for other stuff, what you're gonna left with is F. So by this time, no one told me what F is. I'm very angry with you guys. But it's okay. So F is propofol. So this is a milky solvent. So if you can't identify this, you may it's okay. Learn it now. So propofol is a milky solvent. Yeah. So that's the only milky solvent there. So it's a propofol. So here you need this face toss, so you can't give like a spinal sort of a thing. Otherwise, you can give spinal. But because it's in the face, you have to give propofol, and you do a general anesthesia. I'll tell you why. Yeah, I know this. Then IC tube insertion. That's also a little bit of a hard question, because if you have done surgical and you have seen IC tube insertion, what you use is lignocaine. Usually use lignocaine. Actually lignocaine with adrenaline, no problem of using that. So if you write that answer, I would take that as true. But they say the ideal anesthesia for IC tube insertion is bupivacaine because IC tube එක දැම්ම ගාම කියන්නේ lignocaine වල the anesthesia effect lasts for like 2 to 5 minutes. Some 2 to 5 minutes පොඩි වෙලාවක්. Oh, sorry, 20 minutes. Its onset of action is within 2 to 5 minutes, and the 20 minutes some action there. Bupivacaine has the action for like 3 hours. So IC tube is quite a problematic needs in your chest and under a rib, and rib is all obviously very painful. So if you have a prolonged painkiller action, it's good killer. Bupivacaine, they say the ideal one, but you can definitely do it with adrenaline. That is what we do in our wards also, but you can take either of the two. Then valve replacement in heart failure patients. So that is, I'll give some time for you to think. So that is etomidate. Etomidate is not usually used anymore. It's the only indication is when you have a cardiac problems in a patient like heart failure and stuff, you can use etomidate. Yeah, cardiac failures, and when MIs, avilla surgeries karnakota, because it doesn't do much to your heart, keeps your heart nice and steady. So in that case, you can use etomidate. Carpal tunnel surgery with local infiltration. So what do we use here now? ඔක්කොම වගේ use කරන්නේ. So what's left is A. A තමයි දෙන්න තියෙන එක උතන. Okay මම then there's a reason I put this whole sentence. Oh, carpal tunnel නෙවෙයි tunnel. Carpal tunnel, there's several ways you can do. ඒ කියන්නේ එකක් අහලාදී beer block කියලා එකක් කරනවා. Beer block කියන්නේ අර cup එකක් දාලා උඩින් මේ අතට SBP එකට cup දෙකක් දානවා. Actually cup දෙකක් දාලා you keep it මේ above the blood pressure and you give lignocaine. Lignocaine without adrenaline, lignocaine දාලා ඉවරලා you can do this and then slowly release the cuff from a scene. That's called beer block. It's a regional, it's not local, it's regional anesthesia actually. And local infiltration is you just give it there. So if you are just giving it there for like, especially like body surgeries, not beer block කරන්න, so අක්තමත් කපාගෙන දකනවා නම් beer block is better. But for just local infiltration, it's just with adrenaline is good enough. Yeah, and now we did this one. So if you know this much and if you can like get the general idea from this question, I guess you can do most of in demo you can like match and do indications for this. And also product I didn't put here. They look up about the types of anesthesia. Like you have local එකෙත් එක එක ඒවා තියෙනවා. මේ ඔක්කොම මේ injectables මං ගත්තේ. And there's subcutaneous එක එක creams අනම්මන තියෙනවා, gels and stuff. And also there's when හයට දාන sprays අනම්මන තියෙනවා. So those stuff also take a look because they can come up in auspice. And අනිත් you know, you're supposed to know the local, regional and general anesthesia තුනම. General anesthesia, if you know these three, it's pretty much covered because thiopentone sodiums are not used anymore. I don't know whether that's in your lecture note, but it's an old obstetric drug. It's not used anymore. Ethomidate is obviously used in heart failure people. Ketamine is used. Other drugs are not used. So just knowing this is good enough. Local ටිකක් කිව්වා. Local toxicity කතා කරා. I think that's good enough. The reason I know this is this happened to me. Earlier this year, the December of last year, I got a pimple. I thought it's a pimple because I get pimple quite often. And then it became so big and then it starts smelling all. And then I went to a dermatologist and that woman treated it as acne. And then one day after Ginob's appointment, when I was in theatre, I wanted to leave there early. So I just went to one of my friend's mother who works in the OPD. And she was like, go get admitted. And then when you get admitted, and they said, okay, this is a sebaceous cyst, so we can do it local here. And I was like, fine, if they're doing it local, just do it and let me go here. And I was kept there. This was in a casualty ward. I was kept there for a while. Or I got special treatment, of course. And then later on, they said, when I was in the theatre, this is infected. We can't do this with local anesthetics. We have to go for general. I didn't have time to call my mother. I had my friend there. I was like, Machang Ammata Kepa Kela. I went to the theatre, and that is my first ever surgical experience. And I was put down with propofol, of course. Woke up like 20 minutes after. It was hell of a situation. But yeah, the reason was it was infected. It was pretty large also, and it was on my face. Yeah. Okay, the next question. A 65-year-old male with metastatic lung cancer is brought to the ward drowsy and minimally responsive. He was managed for severe bone pain 2 days ago. You are the intern on call. The nurses say the patient is becoming more difficult to wake with low respiratory rate with pinpoint pupil. So pinpoint pupil is the best clue that you can get here. So what could be the cause of the above syndrome? So he was managed for bone pain, severe bone pain 2 days. So what's the drug you usually give in cancer patients specifically? It's opioids. The pain management is done with opioids, no? You know, I hope that you know the pain ladder. So in cancer patient, you are like basically in the top of the pain ladder, especially bone pains are very severe. So that means they have bone mets. So you use opioids, something like fentanyl or morphine. So what's the cause of the situation? So this is a classic opioid or toxicity or overdose. So when you have pinpoint pupil, just remember you have three DDs. One is opioid, one is organophosphate, and the other one is pontine hemorrhages. So opioid the other features are respiratory depression, causes respiratory depression with clear lungs. When you auscultate the lungs are clear. And also you can get hypertension and go into coma and stuff. Then organophosphate, the difference is you get pinpoint pupils with wet lungs. When you auscultate, they have crackles. You will learn, and they also you get sialoria, so that is organophosphate. Pontine hemorrhages is, of course, you have a lot of other symptoms like paralysis or something like that. Yeah, so Aradeka, you might have to you get to differentiate between the two in MCQs of SPEs also. So know that. Those are the 3 DDs of pinpoint pupils in emergency. What could be the cause? So this is opioid. What is the antidote? So I've only seen once in Maharagama. This happened. So antidote is, I hope you know, the naloxone. Naloxone you give IV. Route of administration is IV. And know the difference between naloxone and naltrexone also, because naltrexone you can't use in this situation. Naltrexone is given for opioid withdrawal. Sorry. Yeah, long term. It's like a long term drug, not withdrawal exactly, but you can't use it here. Naloxone is IV drug that is given something else, some other. It's not exactly the same. Can't remember now. What two are the indications for the initial drug except cancer pain? Now, what are the basically asking two other indications for morphine or opioids. So you can obviously give for you use it very quite often. So you use it for surgical, uh, post-surgical pain management. What else? Just think of two and right one. Go to Hmm. Yeah, think of two and right one. I can't. Brain is not braining right now. This. Okay, this actually came quite when I was doing applied. I didn't know that we had a lecture for stroke stuff here. So this is a stroke question. Apparently the document was uploaded in LMS and I never go to LMS. So you might also get one of these questions and you will never know that it was there. So, but just knowing a little bit is enough. The patient coming with acute onset right side weakness with facial drooping and expressive aphasia was diagnosed as a stroke. Was decided to give the following drug. What is this? Alteplase. You might have come across alteplase in MI management or myocardial infarct. So identify the drug. So this is IV alteplase and its function. So this is a thrombolytic drug. What's the method of administration? Obviously IV. What's the investigation should be done prior to administering and why? So this is a very mamani live question because it's not complete. So in order to complete that, you have to basically to give the drug to decide to give alteplase thrombolysis in a stroke. You have to exclude something. To do that, to exclude, you need to do an investigation. So I hope you know this. Then medicine දෙකක් කළා කිව්වනේ. That is you have to do NCCT. Why? Because there are two types of strokes now. You have ischemic strokes and hemorrhagic strokes. If you give alteplase to a hemorrhagic stroke, patient will die sooner because you are causing more hemorrhage. So you need to exclude hemorrhagic stroke. So you do NCCT. If there's an hemorrhage, it will show in white color. So you exclude that, and then you give the if only it's a ischemic stroke, you give alteplase. So investigation should be NCCT to exclude hemorrhagic stroke. Right to absolute contraindications for the episode. That you might know there's absolute and relative contraindications. So right to absolute contraindications like any past strokes and uh, intracranial hemorrhages within last 3 months. දෙක තුනක් තියෙනවා I can't remember. ඔය වගේ අහනවා right to something, write something and come. There's a list, okay? Just Google it, absolute and relative contraindication. There's a checklist also. You have to make sure that they don't have them. Write two drugs given for secondary prophylaxis in ischemic strokes. It's the same drug that you give in ischemic heart disease. That is aspirin and clopidogrel. Aspirin and clopidogrel, and also statin also. But secondary prophylaxis, that means after the thrombolysis, you prescribe them. You keep them on aspirin and clopidogrel for around 1 month, 4 months, and then you change it to just aspirin. Yeah, so that's for secondary prophylaxis. Hope this question is easy enough. Yeah, so that's the end of my neurology auspice. Okay, I know you have buttload of neurology lectures, uh, but I only put this because other ones I don't think they will come up in auspice. There's no point of wasting time on them. If do you have any questions? Anything related to neurology, not just auspice? Can ask anything. I'll give you like 2 minutes to think of any questions you have. You can ask anything. Huh? Even pathology is fine at this rate. If you don't have any question, tell me what's the first line of Parkinson? What's the first line drug for Parkinson's disease? Oh, I'm not getting any question or answers. මොනවද තියෙන lectures බලමු. anti convulsions කළා. meningitis එකක් තියෙනවා පස්සේ. local කළා. muscle relaxants, of course, there's nothing much. No, we got the MCQ from this. I remember because I got it wrong. Opioid කළා. Parkinson's ප්‍රශ්නයක් හැබැයි දැන් answer එක ආවේ නැහැ තාමත්. Migraine might come, but not as OSPE. I don't know who this S is, but I'm impressed with the answer. It was a trick question, actually. Yeah, you are right. It is the first line depends on the age. Yeah, so in elderly also levodopa, you can't say directly it's the first line because the problem with levodopa is you develop tolerance, no? You get then what do you call end of dose hypokinesia. I hope others know what I'm talking about. So basically, when you and now also don't write levodopa, always write levodopa plus carbidopa. Otherwise, it's problematic. So problem with levodopa is the best drug. If you don't have dopamine, give dopamine. Not rocket science. No? So but the problem is you develop resistance to it. No, not resistance, tolerance to it. So when you develop tolerance, the amount of levodopa that you are supposed to get also increases. I mean, initially you might only need like 2 dosing per day. Then it becomes 4 and then becomes 6. And then afterwards you only can be normal for like 2 hours, 1 hour. Then you have to get the next dose. So you get the symptoms early. And that is irreversible also. ඊට පස්සේ basically levodopa doesn't work. So because of that, you keep the levodopa until the end. If the patient is either elderly or if they have severe symptoms, only you give levodopa. Otherwise, start with something like ropinerol or pramipexole. So you ඊට පස්සේ if they once they don't respond to that, you go for some other drug and then levodopa. That is the basics of it. Same thing that happens with what they call the gambling, masturbation, porn. You get dopamine tolerance. So again, when you give high doses of dopamine to the brain, it develops tolerance. When you give small amounts, like you go to gym, that also somewhat enjoyable, no? Music, it doesn't cause tolerance to it. But when you give high doses of dopamine at once, like in gambling and masturbation, you develop tolerance over time. The same thing happens in Parkinson's when you're treating with drugs. Then how do you treat end of dose hypokinesia? So either you have to give frequent levodopa doses, or you have to give other drugs. Like what were the other drugs? You had some antiviral, ranitidine or something, right? That you can give. Apomorphine you give for on and off fluctuations. Yeah, so take a look at those as well. Yeah, so I'll move on then. You have I think there was another LMS document for me, medicines in dementia. That is too much, man. Just forget it. I still don't know actually. We had the psych lectures, but who cares? How many days do you have for the exam now? Next week or something. කොළුව ටික කර හදාගන්න. Oh, next Tuesday. All right. So we'll move on. If you have any questions, Ane, please ask. It doesn't have to be me. Pharmacology, anything. ayya paper එක හදන්න පිස්සු නේද? Yes. කියලා අහන්න. Okay. Repro also I didn't put too many questions because there's no point. Again, you don't know those stuff to answer. So I put some primary easy level questions. So we'll see. So identify the blister. This is repro. It's not neuro is done. Identify the blister pack given and its primary use. So hope you know what this is. So the only thing that looks like this is OCPs. This is Mituri pack. The was called you better to write COCP. And its primary use is obviously contraception. Explain how it should be taken. So මේ වගේ ඒවා තමයි කරවෙන්නේ. දන්නේ නැහැ කොහොමද බොන්න ඕනේ කියලා. So suppose hope you guys know this, huh? You start the blister pack on the first day of menstruation. පළවෙනි first day that you get the bleeding, you start the first pair and you continue it as it is for 3 weeks, and on the 4th week you get the what do you call it, placebo drugs. I'm not sure. You take the red pills. So red pills contain some little amount of iron, so it helps you with the menstrual bleeding and the iron deficiency. Otherwise it doesn't have the hormone. So you start on the first day of menstruation and you continue, and on the 4th week you take the 7 red tablets for a week, and you let the breakthrough bleeding to happen, and then you continue with the next blister pack. List 3 side effects of the drug. So if you use it, then obviously it's easy to answer. You get some sort of nausea, vomiting. Some people actually develop vomiting and they can't tolerate OCPs. What else? What are the main primary side effects that you have to be concerned about? You get an increased risk of thrombosis, venous thrombosis. So that is the main side effect. And also you can write whomever, I think they get some sort of fluid retention, also a little bit up. But ඊට වඩා a good one would be you get fertility issues. How do you write it? You get prolonged infertility after stopping the drug. That's also a side effect. It doesn't happen to everyone, of course. In case you miss a dose, how to proceed? So those things you're supposed to know. If you miss a dose, what to do? So if you miss the dose, so ideally what they say is that's also you should write. You should take it every day at the same time. Then if you miss the dose, if you remember it within 12 hours, you can take the dose. If you remember it with 12 hours from the usual time, you can take the dose. Otherwise, you continue with the next dose, but you have to use extra contraception method like condom for the next 7 days. If you remember it within 12 hours, you take the dose. Otherwise you take the next dose. Again, 12 hours වලට වැඩි ලං තේරුමක් නැහැ ඊළඟ දවසෙම බොනවා, but you have to complement it with another contraception method, usually the condom, for the next 7 days. In case you vomit a dose, if you vomit it within 2 hours, that's the gastric emptying time. Vomit it within 2 hours, you have to repeat the dose. Otherwise it's fine. But if you have prolonged vomiting, like everyday vomiting, because this is a side effect, no, then you have to use again like condom or some sort of other contraception for the next 7 days. Usually the nausea and vomiting gets better over time. How to modify the dose in prep for elective surgery? Yeah, so the problem is they get monkey with increased risk of thromboembolism. So if you are having an elective surgery, might have seen this in female wards, you have to stop it for 4 weeks. You stop it for 4 weeks and then for a whole month, and then you get the patient down and you do the surgery and you restart in 2 weeks time. That is how you stop it in surgeries. How to advise on use of drug during travel? Again, the same problem because of thromboembolism risk. So if the travel duration is more than 3 hours, you have to ask them to walk in the plane or train or wherever. You have to ask them to get up and walk. Otherwise you can advise them to use a compression stop. අර දාන්නේ DVT කට්ටියට මේ මේස් අන්න ඒ වගේ මේස් දෙයක් දාගන්නවා because of the increased risk of thromboembolism. Write 2 other indications for this other than contraception. Are there any other indication for OCP? COCP, yeah, not OCP. We don't use OCP, no, we use COCP. What does it have? It has estradiol and levonorgestrone, both estrogen and the progesterone components. So write two other indications for this other than contraception. You might have come across this, right? You had a lecture for gynecology. So you use it in a lot of situations, especially if you have dysmenorrhea, menorrhagia, irregular bleeding and irregular periods, you can give OCPs. Also, patients with PCOS, we came across PCOS today, no? So PCOS also you can give OCPs. Patients with endometriosis, you can give OCP. So there are a lot of other indications for OCPs. Of course, it's a bit more advanced when it comes to actual prescribing because you have to identify the risk factors and exclude the red flag signs because dysmenorrhea and menorrhagia can be due to a cancer. So you make sure those are not the causes and then you do OCPs. For like people at our age, like young adults, you can give it no problem. But if the patient is in menopausal or premenopausal age, what are risky? So it's a bit more complex, but those are the indications: dysmenorrhea, menorrhagia, PCOS, endometriosis. Okay, so what is this postino? What is the primary indication for this drug? The emergency contraception method. Not mere contraception, it's emergency contraception. How should it be taken? So this Postino 2 comes in two pills. There's something called Postino 1 also, which is not commonly used here. That comes in one pill. So altogether this is 1.5 milligrams. So one tablet is 0.75 milligrams. So how it should be taken is you have to take this within 72 hours of the unprotected sexual intercourse. Within 72 hours, best taken early. Best if you take within as soon as possible. So must take within 72 hours after an unprotected sexual cause. Best taken with as soon as possible. One after the first tablet, the second tablet should be taken uh, after 12 hours. Yeah, after 12 hours from the first tablet, the second tablet should be taken. That is how you take it. If you vomit within 2 hours, of course, again like OCPs, you have to repeat the dose. Repeat another a tablet for that. Because you get lot of nausea because you are giving kapara, you are giving a buttload of progesterone. That is how it happens. So you uh, prevent the ovulation and the implantation both. So because you are giving a lot of progesterone at once, you get a lot of nausea and so better so you can add this if vomit within 2 hours, repeat the dose and add domperidone with it, so it helps. This is a reliable method of contraception for regular use. Do you agree with this statement? Of course not, because this is used as a emergency contraception, not as a not to be repeated here. On is it plan B or not plan A? So if they ask you reasons, because one is that it giving lot of hormones, so more side effects, not tolerable, and also it's not very reliable. You can't guarantee that it will prevent the fertilization, and also it doesn't regulate the whole cycle like in OCPs. You regulate the whole cycle, so uh, at any point can basically it gives a better protection. This of course doesn't do that, so you can write some of those reasons. State 2 are the emergency contraceptive options. So this is the only one you come across, but in fact there are better options than this. So there are something called ulipristal acetate. Google it and see. It's called ELA. Patal ELA. It's called ELA. Ulipristal acetate, not commonly available in Sri Lanka, but that's the primary one that they use in like US and stuff. Ulipristal acid, because you can take it within 5 days. This is only 3 days and 72 hours. And the other one is copper IUCD. That's the best method. Copper IUCD is the best method. But I think obvious invasive. That is also can be taken within 5 days. This in fact a question in the emergency viva for us, and they can ask it in emergency viva questions. Okay, so I hope emergency contraception is clear. So how should it be taken within 72 hours after unprotected sexual intercourse? The second dose should be taken after 12 hours from the first dose. Obviously, if it's Postino one thing, you can just take it. A 28-year-old woman has delivered vaginally at this question I think it wasn't in the PDF before. I just added this just for my sake. I really doubt that they will ask this question, but because you have drugs in obstetrics, it's good to know something about it. A 28-year-old woman has delivered vaginally at term. 5 minutes after delivery, she develops heavy vaginal bleeding, and on examination, the uterus is soft and boggy. You have done one obstetrics appointment, so you know this. What this is? This is PPH, postpartum hemorrhage. Name the first line uterotonic drug used to manage uterine atony in people. So PPH causes there's 4 T's, right? Tone, tissue, trauma, and thrombin. Commonly, it is due to either tone or tissue, conceptive product. So what is the first line uterotonic drug? So if the tone is not there, you give a uterotonic, so it contracts the uterus. Simple. So that is syntesinone. Syntesinone is synthetic oxytocin. The drug name is syntesinone. You can write oxytocin, which is fine. First you give it as a bolus of 10 units, and then you give an infusion of 40 international units over 15 minutes. But drug is synthesinone. List 2 side effects to look out in this drug. So what are the side effects of oxytocin? So the primary side effects is they can go into hypertension. So oxytocin is a vasodilator, so they can get hypertension and go into a circulatory collapse, and you won't identify it because of she's bleeding also, no? So it can worsen that. Other than that, of course, because it causes a lot of, like, it makes the uterus contract all at once. If it's like a VBAC, that means vaginal delivery after C-section and stuff, so uterine can rupture. If there's a weak point, it can rupture. So uterine rupture is another possible side effect that you have to look out for. And there are other side effects also. They can get like nausea, vomiting, and those are the two main side effects that's in my head. Name 2 second line drugs if the first line drug fails. So there's PPH they will definitely not ask you the PPH management. Because it's so big. So first you start with syntesinone, and if that fails, you go for second line is ergometrine. Ergometrine, of course, you can give it IM or IV. So ergometrine problem is it causes vasoconstriction. So syntesinone causes vasodilation. This causes vasoconstriction. So this can worsen hypertension. So it's somewhat contraindicated. Can't say contraindicated, but not used in hypertensive patients, preeclampsia patient. If you can't do anything else, you use it. But otherwise, it's better not. That's ergometrine. Then also there's a drug called carboprost, which is prostaglandin, and misoprost also can be used, but carboprost is preferred. Those are the 2 second line drugs, and if those fails, you go into surgical methods like non-pharmacological methods like Buckley balloon, and if that also fails, you go for surgical methods. You divide the uterine artery or even internal ayya, it goes on. State one important side effect of each second line drug. So ergometrine, it can cause hypertension. Carboprost, all the prostaglandin drugs can cause bronchospasm. That's the one that you look for, like, especially if they're asthmatic, can cause bronchospasm. And also it can cause nausea, vomiting. Name 2 other indications to the drug mentioned in 1. So syntesinone, what are the other indications? If you write oxytocin, that's totally fine. It's actually 2 drugs, but syntesinone is synthetic oxytocin. Oxytocin is pure oxytocin. Name 2 other indications. So you must have heard, of course, you can use it for labor augmentation, right? Labor එක progress වෙන්නේ නැත්නම් you can give a synthesin. You can put a syntesinone drip, so you progress the labor. Artificial augmentation, in artificial induction here. That in as induction, not augmentation, induction. Then අනිත් එක තමයි must have heard this active management of third stage of labor කියලා අහලා ඇති. So labor එක බෙදෙනවා 3 stages වලට, right? First stage is until the cervical dilatation happens, then the second stage is until the baby comes out, third stage is until the placenta comes out. So third stage එකේ active management, there's active and passive කියලා දෙකක්. Passive කියන්නේ you don't do anything, you just monitor them. Active management is you do something. basically to prevent PPHs. So what you do is you give syntocinon. Give 10 units of syntocinon bolus as soon as the baby's anterior shoulder is delivered. That's how you do it. So the uterus contracts and the placenta comes out. So those are the two indications you can write. Again, repeating for the artificial induction of labor or active management of the third stage of labor. Okay, so that's the end of that also. I only put 3 questions because I think that's only deserving of that many questions. If you have any other questions, you can ask it now until I load up the other doc. Base මල්ලි එහෙම ඉන්නා නේද ප්‍රශ්න නැද්ද ඔයාලා? Okay, I don't want to scare you guys, okay? I actually lost my farm, what do you call it? Distinction, the first class, I can't remember. Whatever that in Cat 4. Because this stupid, you know who it is, made the paper so freaking hard and I don't like farm. I don't know why I'm doing this. OSPE also, I don't like farm. Now I like farm because the clinical farm is fun. This farm where you can take the drug and you see what you can give it like උදේට බෙහෙතක් උස්සන් ගිහින් දෙන්න පුළුවන් හැමෝටම එහෙම you don't practice medicine. What you do is the other way around. So I didn't like it and I actually lost my whatever that in Cat 4. I had good marks. Even Cat 4 I had good marks, it's just I couldn't compensate for some other marks I lost. Uh, but Cat 4 carries a lot of marks for farm because then තියෙනවා module 4ක් and also antibiotics, which I believe that it should be in IPD, not IPD, the first term, because that's like what you commonly see in wards. I didn't had any idea about antibiotics until it comes to this module and it was pretty late after. So just make sure that you try your best until next Tuesday because it matters. It matters until the exam ends, of course. It doesn't matter. But yeah, try your best. And also microbiology. That's the other shit subject. Okay, I guess you don't have any questions. There's another whole lecture that I didn't even touch on. There's something called drugs in gynecology. ඒකෙම ලොකු දෙයක් අහන්න එහෙම නැහැ ඉතින්. Prescribing in pregnancy and lactation, I think you might have had that lecture. There's no point of studying that lecture to prescribe in pregnancy and lactation. Drug එකෙන් යන්නව දැනගන්න ඕනේ ඉතින් මොකද්ද අවුල කියලා. I would have put a question from Pharmacology and ask about that, but what's the point, right? I've only seen one Pharmacology person. That's also not in the hospital. It was in the canteen. Patient just walked in. Okay. Pharmacology again are thalidomide වල එන්නේ proximal lymph කොට වෙන්නේ. Okay, so the IPD is moving on. Yeah, IPD also I didn't put a lot of questions. I stick to antibiotics and we'll talk about that later. Okay. 12-year-old boy presented to you with non-pruritic morbilliform rash. I hope you know what morbilliform is. Morbilliform is maculopapular, same thing. Rash which started in trunks, now present in limbasis, so it has spread. Which was previously he was previously treated for sore throat with oral antibiotics, which still hasn't resolved. On examination, patient was febrile and had posterior cervical tender lymphadenopathy. What is the diagnosis? What do you think this is? Any guesses? Yes, කරපම්පා. Rash එකක් තියෙනවා previously treated with antibiotics and lymphadenopathy එකක් තියෙනවා. That's enough for you to know the answer. Someone responded. Nice. Yes, it is. Nice. How many farm IPD OSPEs usually come අයියේ? ඔක්කොම 20යි නේද එන්නේ ඔයගලන්ට? ඔය 10ද? 10ක් එනවා නම් අනිවාර්යෙන් 3කට අඩුවෙන් එන්නේ. 20 නම් 5ට අඩුවෙන් එන්නේ. and මට මතක හැටියට අපිට ආවේ 4යි. There's going to be a buttload of micro questions this time, මොකද මේවා නැහැනේ මොනවාද පැතොලොජි ඇත්තෙම නැති තරන්නේ. ඉමුනොලොජි අහන්න දෙයක් නැහැ. parasitology එනවා parasitology. I'll ask you a funny question. අර පස්සේ මේ අන්තිමනේ කරුණාම මේ when you get anaphylaxis you usually don't give that drug no afterwards. I think I asked that question later on. Do you know any drug, any drug that you do give after getting anaphylaxis? දන්නවනම් මට දාන්න පස්සේ. Okay. Yeah, so your answer is right, Mali. It's EBV. But because I know that's a problem. This has happened to me quite a bit of time. You think the answer to the first question is EBV because the question is not clear. But then I asked the second question as causative agent. As a causative agent is the EBV, So they thought the first question is not EBV. The diagnosis should be, what is this rash? EBV can cause rash, but not this rash. Like, what is this clinical scenario and rash? I'm obviously not talking about microbiology. It's a farm question. So this is called ampicillin rash. Not ampicillin, amoxicillin rash. Okay, ampicillin rash can pull up. So otherwise you can write rash due to treating EBV with amoxicillin. Even that is fine. Otherwise this is known as amoxicillin rash. So what happens is when you give the sore throat, what's the problem here? You can guess the problem. What usually sore throat is due to viral infection. Could be CMV, EBV, something else. Okay, adenovirus, whatever. But there's a bacteria that causes. There's several bacteria that causes sore throat. And the commonest of that is strep pyogenes. So strep pyogenes, you have to give oral antibiotic. So this, whoever the doctor, which is me, have given oral antibiotic. That must be amoxicillin. That's a common drug you give for sore throat. But when the sore throat is due to EBV, instead they come with the rash. So that is amoxicillin rash. So what is the diagnosis? That causative agent is EBV. Causative agent is in EBV. Diagnosis you can write amoxicillin rash secondary to infectious mononucleosis also. The clue is lymphadenopathy. EBV is otherwise known as infectious mononucleosis, otherwise known as fever with lymphadenopathy. That's another name that has lymphadenopathy in the name. Basically, that is the commonest cause of cervical lymphadenopathy with sore throat. Remember like that. Not that others can't cause sore throat, and lymphadenopathy can, but this is the commonest. First thing you're supposed to think of when you see lymphadenopathy in the neck. That's the Epstein-Barr virus. So explain the cause of this rash. So this is non-allergic. This is not allergic reaction. This is non-allergic immune-mediated reaction for amoxicillin with background infection of EBV or infectious mononucleosis. We have to write that whole thing. So that's the cause. So non-allergic immune-mediated reaction. How would you treat him? So again, if it is due to a drug, first thing you do is you stop the drug. First you would stop the amoxicillin, and of course EBV doesn't need amoxicillin. It's a viral. You stop the amoxicillin and you treat them supportively. That's enough. I mean, like any viral infection. So, but if in sore throat case, you have to be vigilant about their hydration, because වතුර බොන්න අමාරුයිනේ, කන්න බොන්නත් අමාරුයි. කන බොන එක නම් ප්‍රශ්නයක් නෙමෙයි, මැරෙන්නේ නැහැ දවස් දෙකක් කෑවේ නැහැ කියලා. But වතුර බොන එක, if they go into dehydration, so that is supportive management. You have to make sure that they are hydrated well and stuff. If you have time, write those as well. Otherwise, this is enough. So this is amoxicillin rash, which quite often comes in MCQs and in OSPEs එනවා ඇති. ඉතින් මම එකක් දැකලා තියෙනවා අපේ හදපු ඩොක් එක. A patient who presented with fever, fleeting joint pain, found out to have positive ASOT. Patient later developed a murmur in the mitral area. He was successfully treated with IV penicillin. Okay, what is his cause now? What's the clinical picture? Fever, fleeting joint pain with ASOT positive. This is rheumatic fever. Might have come across it in CVS also. So rheumatic fever due to strep, right? That's why ASOT positive. And then you have the murmur. So that means it has gone into carditis and it has complicated with valvular valvular involvement. So this is quite complicated then. So successfully treated with IV penicillin. That means the ASOT is also coming. It has been negative and the patient is fine. But now ඔගලන් තිබ්බනේ antibiotic prophylaxis හරි මොකක් හරි කියලා lecture ඕක explain කරනවා. Now the problem is if they get another infection, same rheumatic fever, they are going to get a very worse situation of the heart failure. As in their valves are already damaged, they can get further damage. So you have to make sure that it doesn't happen. So therefore you prescribe them with prophylaxis, especially patient with carditis and valve involvement, you give them prophylaxis. So that is your basis for giving prophylaxis. What is a drug of choice? Another. There are but a lot of penicillins, no? IM penicillin G කියයි penicillin B ද මොකක්ද කියලා එකක් තියෙනවා oral දෙන එක. And then you have benzathine penicillin, benzene penicillin G. Benzyl penicillin is penicillin G, and you have benzathine penicillin, procaine penicillin, you have penicillin V, this is phenoxymethyl penicillin, I think, and then penicillin T. You have to know why when you use each of those drugs. So penicillin, IV penicillin during the infection is penicillin G, right? But when you are giving prophylaxis, you can't give IV penicillin because you need it to be for the long term. So instead you give benzathine penicillin. You should give an IM පස්සට ගහන්න ඕන මේ ටුෂියකට. It's very painful. It's a very hard thing to watch in kids because it's very painful drug. But it's long acting. You give it once a month. So the answer is benzathine penicillin. Not a benzyl penicillin කියලා ලියලා ඉන්න එපා, වැරදි. Benzathine penicillin has a long acting maker, and this is like the only indication it has also, like common indication. How often the drug should be given? Once a month. Does anyone know indication for procaine penicillin? Procaine benzyl penicillin. Procaine is a local anesthetic, of course. It's there in the local anesthetic lecture. Does anyone know? Ansaka. Syphilis, nice. That's high yield. The high yield not high yield, but it's high level. Good that you know it's syphilis. Yeah, not syphilis. පොඩි එකක් තියෙන වැරදි එක syphilis වල තියෙන penicillin IV. It's neurosyphilis. Neurosyphilis වල you get lot of neurosyphilis වල there's a ලස්සන නමක්. You call it some insanity. මගේ නම හොයලා කියන්න. Basically they get a lot of symptoms. They get hemiplegia, they get seizures, they get mood swings, and there are mood changes, personality changes. That's why I call it insanity. Pistu හැදෙනවා. And also they go into they get a lot of pain, neuropathic pain. And on top of when you give the drug also එතන රිදෙන්න ගන්නවා ඒගොල්ලන් දරා ගන්න බැරි වෙනවා. So ඒ හින්දා තමයි you give a local anesthetic and give the drug. Procaine benzyl. You can give it in neurosyphilis, syphilis always, but syphilis you give IV penicillin. It's neurosyphilis, but good, huh? Was it there in the lecture? Okay, patient who was started, I'm impressed. Patient who was started on IV penicillin developed wheals and subsequently breathing difficult disease in very near clear and cut anaphylaxis. Difficulty in breathing difficulty and reduced BP within 40 minutes of administration. So anaphylaxis, of course, if you go into their for a technicality, they say majority develops within 20 minutes time, but 90% no something develops within 1 hour. So even within 1 hour, everything you have to consider for anaphylaxis. That's why මොකක් drug එකක් දීලා injection ගහම minute 20ක් තියාගන්න, because majority develops within 20 minutes, but within 1 hour you have to consider that as anaphylaxis. That's why 40 minutes then. මෙහෙම මමත් ළඟ ඉගෙන ගත්තා වෙදී මම ඉතින් use කරනවා තැන් තැන්. What's the condition and what is the immediate drug to be used? This is anaphylaxis. Immediate drug is දන්නවනේ දැන් නේද මේ IM අමතකත් වුණා. epinephrine adrenaline 0.5 milligram 1 into 1000. Patient in initial contact reveal history of allergy to seafood. Patient කිව්වලු seafood allergy එකක් තියෙනවා කියලා, but not for drug. What more could you have done to prevent this? ඔය වගේව අහන්න පුළුවන් because it's OSPE and practical. So you could have taken a very detailed allergic history. And of course, if the patient is already atopic, that means they have features of atopic. When allergies තියෙනවා, they can have asthma, they can have PNSA, what you call it, hay fever and stuff. So product, you have to be vigilant about it. Sometimes, especially if they have like lot of different allergies, then you can of course give a hydrocortisone dose and give the drug if you are like very suspicious. But okay, the answer expected was specifically for penicillin, you can do something called intradermal testing. You inject a little bit of penicillin into the dermis, intradermal, and then you let it be for like few minutes, like 10 minutes. And if it makes a wheel like that means he's allergic to it. So better not to give it afterwards. So you could have done intradermal testing of penicillin. Might have been there in your lecture also. Because penicillin වල තමයි anaphylaxis විකාර ගොඩක් එන්නේ. What drugs should be avoided in the future and how would you make sure to prevent this? Is a one whole MCQ in 2015 hari 16 hari paper. ඔම drugs ටික දීලා penicillin allergy එකක් තියෙනවා what should be avoided කියලා. So penicillin allergy තියෙනවා of course you can't give any penicillin. You can't give aminopenicillin, that is amoxicillin and ampicillin. එකක් දෙන්න බෑ. You can't give cephalosporin. Like basically all the beta lactam. You can't give beta lactam. You can give cephalosporin. Then you have carbapenem and meropenem, which I'm not sure whether you can give or not, because usually you say you can't give because it's also beta lactam. But in that paper they have taken it as you can give because it's too much for you. And cephalosporins, like if you have penicillin allergy, there's like 20% risk you can develop allergy to cephalosporins also. But for carbapenems, it's less than 1%. Unlikely. Like a true but write it. No one would say it's true unless it comes in MCQ. How would you make sure to prevent recurrence? That also you can do something. You can make sure the patient is educated about their penicillin allergy, and also you make a note. You make a clear note that he is allergic to penicillin. And also there are wristbands saying you have wristbands noting your allergies where they take it everywhere. Those things you can do. And the best answer is let the patient know. So යන තැන කියනවා මම allergic කියලා. එහෙම කියලාත් දුන්න වෙලාවල් තියෙනවා හැබැයි. Like a very recent one also happened in Prof. Okay, a අවුලක් නැහැ කියලා හිතනවා මාරි කිව්වොත් අහන්න. A 2-day-old baby who has been treated for neonatal jaundice developed bulging fontanelles. So neonatal jaundice and then developed bulging fontanelles, and during investigation LP came positive for bacterial meningitis. What are the common causative agents in neonatal meningitis? Someone type it out. Microbiology man danne naha. Okay, so something to notice here, that one is that this is also co-complicated with neonatal jaundice. And අනිත් එක තමයි මේ neonatal meningitis doesn't present well. They don't have very specific symptoms. What they usually come with lethargy. කොහොමත් ඉතින් බබෙක් lethargy වෙනවා නම් you have to be පොඩ්ඩක් vigilant. And also if the babies always sleeping and not very active, floppy babies and not sucking milk, basically amma කියනවා නම් මට හොද ළමෙක් ඉන්නවා කියලා you have to be පොඩ්ඩක් vigilant, because ළමයි හොද නැහැ කෑ ගහනවා හැමදෙස්සම අඬනවා. එහෙම අඬන්නේ නැති කෑ ගහන්නේ නැති දෙන දෙයක් කලන දෙයක් බලන් ඉන්නවනේ පොඩ්ඩක් අවුල්. So lethargic floppy babies, you have to suspect meningitis, and this patient of course you will get bulging fontanelle. That's a feature of meningitis in kids. Okay, I'll skip that. Okay, what are the common causative agents? Someone type it out. Doctor decide to prescribe a cephalosporin anemia. This is neonatal meningitis, 2-day-old baby. Doctor decided to prescribe cephalosporin and a penicillin. A එකේ කියනවා amoxicillin no ampicillin. B එකේ කියනවා cefotaxime or ceftriaxone. Pick the suitable antibiotic regimen, give your reasoning. So should it be amoxicillin or ampicillin? And why did you give amoxicillin or ampicillin? That you supposed to know first. Um, it's what do you think? I hope you know the answer. It's ampicillin. It's not amoxicillin. Amoxicillin is a tablet you take. Ampicillin is the IV prep. So any meningitis you treat with IV medications. Like, general rule that for meningitis you treat with IV preps. So ampicillin is the answer. Why do you give ampicillin? කවුරු මම එව්වේ නැහැ causative agents ටික. මේ the causative agents මොනවාද? You have strep B, which is the commonest one, අර galacti මොකද දෙක කියලා. A galacti. And along with that you can get E. coli by බබාගේ එළියට එනවා. අන්න සමතුලිත. Yes, that's yeah. So E. coli හැදෙන්න පුළුවන්. That's like the second commonest cause of neonatal meningitis from the mother's tract. And then other uncommon name, one of the uncommon ones are listeria. So listeria can happen in two ends of the spectrum, very neonates and very elderly. So both you have to cover with ampicillin. Ampicillin is the drug of choice for listeria. So that's why you give ampicillin. Cefotaxime or ceftriaxone. So this is a product high yield question. Answer is cefotaxime. Of course, in pediatric population, you can use both. Only thing is that there's a difference in the dosing. Cefotaxime you have to give frequent dosing. Ceftriaxone you repeat it every 6 to 8 hours. But in neonates, the ceftriaxone is contraindicated because it causes something called biliary sludging. Basically, it can worsen the jaundice. So that's why I put the question that he has neonatal jaundice here. So if you give ceftriaxone, it would worsen the neonatal jaundice. So anyway, as a general rule, you don't give ceftriaxone in neonatal meningitis. It's cefotaxime. That is your reasoning. The biliary sludging. Okay, next question. I can't get the end. The guy. 65-year-old woman admitted for treatment for a community-acquired pneumonia. She was started on an oral antibiotic. 2 days later, she developed dizziness and palpitation. On hospitalization, the ECG was done and showed QT prolongation. So, question is very easy. They also say the problem. She was on furosemide for heart failure. Her serum potassium was 3.1. So, I hope you know the normal range. It's 3.5 to 5.5. What is the most likely cause for her symptoms? So, symptom means dizziness and palpitations. So dizziness and palpitations. And when you have some sort of arrhythmia, so it's probably an arrhythmia due to QT prolongation secondary to the usually antibiotic, right? They have said that she's on antibiotics. So that is the answer. What is a serious arrhythmia this condition can complicate into? So might know that there's broad complex and narrow complex arrhythmias. So QT prolongation, you go more towards the broad complex arrhythmias. So those are, you can go into ventricular tachycardia and ventricular fibrillation. And then cardiac arrest. So you can write anything. Ventricular tachycardia, ventricular fibrillation, cardiac arrest. What risk factors are present in this patient that may have precipitated this condition? We've written the answers. Yeah, so that is one is that patients already hypokalemic. So it's a product when you have electrolyte imbalances, you are more likely to get arrhythmia. And also patient has heart failure. That's when you have a structurally damaged heart, the more likely it can malfunction. And also she's elderly, and then if the mycoplasma වගේ නම් what is the oral antibiotics IQ this is suppose මම ඔළුවේ තියන් දැම්මේ something like erythromycin, because mycoplasma you give erythromycin and that can cause QT prolongation. Mycoplasma is of course atypical community acquired pneumonia. Yeah, so mycoplasma also can cause a lot of electrolyte imbalances, so that also can be the one of the precipitating factors. Write another antibiotic which can show similar ECG changes. Don't mind my sentences now when you can type. Yeah, so what are the other antibiotics that shows QT prolongation? You have fluoroquinolones. Fluoroquinolones sama ඔළුවට ආවේ. I think I typed out the other rest. Yeah. Yeah, so that's that question. If you have any further question, ask. The antibiotic I had in mind was erythromycin for community acquired pneumonia, because otherwise, for strep and stuff, you give ceftriaxone, something like that, no cefuroxime. So those actually doesn't cause QT prolongation. Sorry. Then a 32-year-old female presented with profuse watery diarrhea. She was treated 1 week ago for bacterial vaginosis. Examination revealed diffuse abdominal tenderness without guarding. She also mentioned about taking antibiotics but cannot recall the name. What is the most likely diagnosis? A patient coming with diarrhea where she has been treated for something else with antibiotics. Does anyone know what this is? This is a side effect of antibiotic. Bacterial vaginosis was the drugs you use. Two drugs you can use. Yeah, PMC තමයි, private medical college. Yes, you can use metronidazole and also you can use clindamycin. හරි. clindamycin නෝද මෙතන මම ඔළුවේ තියන් හැදුවේ clindamycin. I'll tell you why. Then metronidazole also can use to treat bacterial vaginosis, and both of them can cause PMC. PMC is pseudomembranous colitis. Otherwise, this is Clostridium difficile diarrhea. That is the diagnosis. Otherwise, pseudomembranous colitis caused by Clostridium difficile. Yeah, so clindamycin and metronidazole, both drugs can cause pseudomembranous colitis. Yeah, so what is the investigation you would do to confirm suspicion? I think you can do a stool sample. You can you can check for the toxin of the clindamycin. Sorry, not clindamycin, Clostridium difficile. That's one way. Also, you can do the culture of stool culture. That's all that. But best way is you can do a CT. If you do a CT, you would see the pseudomembrane, like for the opacity එකක් පේනවා මේ colon එක දිගේ. Otherwise, ඉතින් colonoscopy එකක් කරන්න ඕන. Whatever you write at your level, it's good enough. මොකක් හරි investigation එකක් ලියන්න. Either you can look the pseudomembranes or you can look for the Clostridium difficile. Either of the two. Write to appropriate treatment for this condition. Does anyone know how to? Ayya, isn't it? Yes. Okay, I'll tell you. So write to appropriate treatment. So that's why I asked for both of the drugs, because I want to clarify that. So the first line drug is vancomycin. Might have come across vancomycin, right? So vancomycin is a first line drug. Vancomycin normally there's two preps. There's IV vancomycin, there's oral vancomycin. So method use can oral vancomycin. The reason for you to treat something in the colon, you need the drug to be on the colon. So oral vancomycin is not very well absorbed. Instead, it stays in the gut and it treats the pseudomembrane colitis or the Clostridium difficile. That's the only indication for oral vancomycin as far as I know, because everything else is IV vancomycin. And the other drug is, if you have severe pseudomembranous colitis, along with oral vancomycin, you can give IV metronidazole. Your problem is correct. So metronidazole both can cause and cure pseudomembranous colitis. It can cause the problem, and also it's used as a treatment in severe pseudomembranous. Not the first line, of course, but in severe disease, you can use it. Yeah, right now there's no reasoning for why, but you can. Yeah, so that is that. After I had that surgery, I was using clindamycin, and in that time I got a diarrhea, and I was convinced that it was pseudomembranous colitis, but it was not. I don't know what it was. It went away, but I was convinced. Yeah, so then because I couldn't cover everything, I put again like a sort of like a summary. So these are the important side. These are not all the side effects. Of course, don't rely on just this. But these are the drugs that cause QT prolongation. Macrolide and fluoroquinolones are the known antibiotics. Fluconazole is basically antifungals or azole drugs can cause QT prolongations. What is the major side effect of amphotericin? Someone put it in the chat. Then Steven Johnson, of course, we already talked about sulfonamides. Macrolides can cause Steven Johnson. Even ampicillin and amoxicillin can cause Steven Johnson. Those are the antibiotics. Nephrotoxic drugs, aminoglycoside. Aminoglycoside wala nephrotoxicity is a reversible reversible dose response one. Mean dose related side effect there. Vancomycin also can cause nephrotoxicity. මෙහෙමයි. You can put sulfonamides also here because it causes interstitial nephritis, and also penicillins. මට දැන් මතක් වුණේ. Because they technically think they cause interstitial nephritis and cause nephrotoxicity. Ototoxicity, well known drug in aminoglycoside. So this is the reason that you don't give it in children. So aminoglycoside considered contraindicated in pediatric population because of this reason. Aminoglycoside causes irreversible toxicity. Of course, you can use it with proper drug concentration monitoring, which we don't have capacity in LRH. So අපි හිතාගෙන දෙනවා සමහරක් වෙලාවට හරි ඩෝස් එක දෙනවා කියලා, but usually it's considered contraindicated. There are certain indications where you don't have any other option in fact. Vancomycin also can cause ototoxicity. Then hemolytic anemia in the drugs, penicillin. If you go back to your BLS and look at that hemolytic anemia lecture එකට අන්තිමටම හතරක් තියෙන්නේ මේ immune mediated one. එතන පළවෙනි එක penicillin. ගිහලා බලන්න. And cephalosporin also similar way. Nitrofurantoin and sulfonamides can worsen G6PD deficiency. Photosensitive drugs, tetracycline, fluoroquinolone, very well known to come with red rash. Okay, photosensitive drug ya OSPE එක දුන්නොත් අතුරු ගන්න කොහොමද? And that's a good question because we got a question one time, and then at that time I couldn't reliably say it was photosensitive. පස්සේ තමයි click වුනේ. If it comes in very simple, if it comes in exposed areas, බෙල්ල වටේට, අත්වල, මූණේ, බෙල්ල වටේට තමයි usually they give collar area එකේ, because that's sun exposed. Fluoroquinolones are very very well known to give. Tetracycline also can. I don't know whether you guys used what do you call it, sketchy to study antibiotics. That was my lifeline ee kale. Still is sometimes when you think of a certain drug, my mind goes to sketchy. I only use for antibiotics, of course, because it helped me to remember a buttload of information just for antibiotics. If you use it for everything, I don't think it's useful. But if you just use something like one type sort of a situation, it's good. And also microbiology. There's a common MCQ asking whether gentamicin or amikacin is more nephrotoxic. There is. Why would they ask about amikacin? That's not a very used drug. I'll check on it, Mali. I'm not sure. I have a feeling it's amikacin because gentamicin there's oral and IV prep both. Amikacin usually IV. I'll look for it. Okay, can't give you a proper answer right now. More ප්‍රශ්න antibiotic and මෙතන unique side effects. Okay, ඒකට විතරක් unique ඒවා වෙනම දැම්මා. So chloramphenicol you can cause aplastic anemia. This is why we don't use it anymore. Because chloramphenicol still used for two indications දෙකයි තියෙන්නේ. එක්ක meningitis වල use කරන්න පුළුවන්. එක්ක අර Rocky Mountain fever කියලා එකක් තියෙන්නේ, which is not seen in Sri Lanka, but අපිට තියෙන්නේ මේ scrub typhus नु. When you have Rocky Mountain fever in northern America and stuff, you can use this. Typhus වලට මොකක්ද දෙන drug එක? මම put it in the group. Typhoid fever. You're supposed to know that. Linezolid. So you're supposed to know MRSA වලට දෙන drug. The MRSA වලට you can't give every drug. Okay, that will also ask as a question. Can you give? Yeah. So for scrub typhus, you can give doxycycline. Doxycycline is the first line drug. Good that you know that. Because it's a very scrub typhus comes out of මොකද case එකක් තියෙන්නේ මේ prolonged fever and pyrexia of unknown origin. So scrub typhus is one of the DDs, so you have to know about that. What are the drugs that can cover MRSA? Okay, true or false? Can you give carbapenems or meropenem to cover MRSA? Someone put it. I'll read this. So linezolid, of course, can cause bone marrow suppression, but the very specific side effect it has is serotonin syndrome with SSRI. If only if it comes in MCQ, time because you don't know what serotonin syndrome or SSRI. SSRIs is selective serotonin reuptake inhibitors that you use in depression and psychosis situations. So you don't know that, no, but serotonin syndrome නිකන් අමහලා තියාගන්න. Daptomycin also not very commonly used drug which can cause myopathy like similar to statin. Rifampicin you know can cause red orange urine and මේ CYP450 inducers අර පුළුවන් නම් අර mnemonic එක දාලා මතක තියාගන්න. Good if you know that. Isoniazid of course can cause peripheral neuropathy because of this pyridoxine deficiency and hepatitis. Ethambutol known to cause optic pneumonia. These are what TB drugs, anti-TB drugs. And out of the anti-TB drugs, the most hepatotoxic one is pyrazinamide. Then metronidazole, the other common question they ask is whether it causes disulfiram-like reaction. So that means you get දැකලා තියෙනවද මේ දැකලා හරි විදලා හරි තියෙනවද how the what do you call it hungover. Have you been hungover ever? Like එහෙම වෙලා තියෙනවනේ you would know. Disulfiram, when you take metronidazole with alcohol, what happens is your alcohol dehydrogenase get inhibited, so you get a lot of something accumulated. You get hungover feeling, like you get like you get a very bad headache, and the characteristic side effect is you get flushed because you get a vasodilatory reaction where you get flushed. And then also you can get hypotension again because of the vasodilation. That is disulfiram-like reaction. Clindamycin is the highest risk for Clostridium difficile colitis, that is pseudomembranous colitis. So no one told me whether carbapenem can use for treat MRSA. I'll give you 1 more minute for that. So then you're supposed to know the teratogenic antibiotics. So tetracycline, of course, you can't give because of this tooth discoloration. Enamel enamel hyperplasia and then it becomes some weird color like copper color. Copper deposition so you can't give that. Aminoglycoside you can't give because of the ototoxicity. This happens in බඩේදී also pregnancy get contraindicated, pediatric contraindicated. Fluoroquinolone causes cartilage damage, right? Sulfonamides actually you can use except in late pregnancy where you are ceftriaxone wage scene එකක් තියෙන. It displaces bilirubin for albumin, so can worsen the kernicterus. Chloramphenicol we don't use it because it can cause great baby syndrome. Metronidazole and triamterapine, if you can remember this triamethoprim, because of that folate deficiency neural that can cause neural tube defects. But may පළවෙනි හතර මතක තියාගන්න. Okay, then antibiotics contraindicated in children, again tetracycline because of the same reason, fluoroquinolones again because of the same reason, chloramphenicol forget that, sulfonamides it can cause kernicterus. If you want, add ceftriaxone here also, and මෙතන මම දාන්න අමතකුණා මේ aminoglycoside because it's ototoxic. Can't. Yes, carbapenem you can't use in MRSA. MRSA, you have to know what drugs can be used. Usually what we use is vancomycin, linezolid, and daptomycin. Those are the best drugs. There are other drugs that you can use. Like you can use 4th and 5th generation cephalosporins, kefapime and there are certain tetracyclines you can use. There are drugs that you can use, but when MRSA is basically big guns. Yes, Vanco, Clinda, yes, Clinda can use linezolid, dox. Yeah, doxycycline, daptomycin, ඔක්කොම හරිවා කියලා තියෙන ටික. ඒවා UCFM administrative block එකෙන් දායි. Anyhow, but yeah, when you get the MRSA, you don't use usually Clinda and doxy. You go for Vanco, linezolid, ලංකාවේ නම් dapto තියෙපොත් දෙන්න පුළුවන්. Those are the first line drugs. අරවත් you can think. You don't use it. Okay, so that's the end of it. Okay, so again I didn't cover a lot in IPD because there's no point. I'll send the modified newly added PDF තව ටිකකින් තව මොනවද ප්‍රශ්න තියෙනවද අහන්න. Meanwhile, make sure to study the farm anti-malarial stuff. They can ask anything from any drug in anti-malarial. I don't know why. There's no point. There's literally no point of asking them, but they do. Like even artemether lumefantrine and artesunate is different. Know the difference. When you treat uncomplicated malaria, you use artemether lumefantrine combination oral 6 doses in 3 days. But when you have complicated malaria, that is usually Plasmodium falciparum, right? That is when you have confusion, coma, anammanam vikartikama. You can't give oral drugs no. එතකොට you use IV drugs. That is artesunate. ඔය දෙකේ කෙහෙල් වල පැටලෙනවානේ. අරක තියෙන artemether මේක artesunate. එතකොට you give IV drugs for 24 hours or until they can tolerate oral. ඊට පස්සේ you give the normal මේක. And then both of those I think you can't use in pregnancy, and then you have to know separately what to use in pregnancy. Anti-malaria, I don't know why they love it, because at the end of the day, when you get the patient, you send the patient's BHT to the microbiology department. They tell you what to do. Anti-helminths, of course, albendazole, mebendazole, they put up balagana. If those drugs don't exist, their department also doesn't exist. Filaria, but you give DEC and ivermectin. Antifungals, no one told me amphotericin or the side effect. So if you have seen prescribing amphotericin, you can't. You can't. A consultant can't prescribe amphotericin. Haven't noticed this. You have to send the BHT with the referral to the microbiology department, saying that there is a patient with suspected antifungal or whatever, and you have to get their permission, and they only give the drug. Nurses you have to send it from the microbiology department. That because it's very toxic. What is the toxicity it can cause? Yes, it's highly nephrotoxic. You're right. Amphotericin is very highly nephrotoxic. Usually either patient die from the fungal infection, because amphotericin use it has to be a very severe fungal infection. The commonest I've seen is in the ENT wards, where used for mucormycosis. There's something called black fungal infection. TV saying that black fungal infections are increasing in incidence. News first time. In that you use amphotericin commonly. Either you die from the infection or you die from the amphotericin. And and also it's given IV. There's a lot of hydration part also. Then topical antifungal, know a little bit about that, especially. So this grisophylline comes in MCQs, no? Because when you use it, you can't father babies for 2 years. Then other commonly used antifungal is the azole, ketoconazole, that causes liver toxicity. I'm just telling out of my head, on top of my head. Antivirus, of course, I can't remember anything except what is a common use drug for HIP? Sorry, HSV. HIV drugs ටික බලා ගන්න, because ඔතනින් පස්සේ ආයෙ එක repeat උනේම නැහැ අපිට. Even now I don't remember them because it never repeated for us. ඔය විය කියලා drugs ටිකක් තියෙනවා. Acyclovir. So acyclovir, of course, you come across. ඒකේ side effect is it's also renal toxic, nephrotoxic. Yeah, so that's the end of it. පොඩ්ඩක් බලා ගන්න UTI වල දෙන chemoprophylaxis. Tell me what the chemoprophylaxis drug, what do you give for cellulitis? Cellulitis, usually penicillin, oral penicillin. For rheumatic fever, we already talked about it. Benzathine penicillin, not benzyl penicillin. That's different. One is long acting. Then other thing prophylaxis cases for leptospirosis. Leptospirosis is the patient is like a farmer, and then you can't help but get exposed to water and maybe water sources and stuff. Get doxy, yes. You treat with doxy, you as the make also you give doxy. Cellulitis කියලා. UTI පොඩ්ඩක් බලා ගන්න. ඒක පොඩ්ඩක් මේ සංකීර්ණයි. Then surgical prophylaxis also. Surgical prophylaxis, remember, it's best given. This is a question that came across in MCQ. Best given just before the incision is made. But they say at least within 6 minutes කියලා. But best is just before you make the incision, you push the drug. අරහන් anesthesia patient මේ register ඇවිල්ලා drug එකක් දෙන්න ඕනද කියලා, මේ antibiotic දෙන්න ඕනද කියලා from the surgeon. And also in the WHO checklist is also there. Okay, do you have any question, anything from any topic? Otherwise, I'll put my number here. You can message me so I can get back to you. Yeah. I hope this was productive. එදා MSK එකෙන් මොකක් හරි ප්‍රශ්නයක් තිබ්බොත් ඒකත් අහන්න. I know that you didn't watch it, so go watch it if you can, because I'm pretty sure MSK would be much more useful for OSPE than these three combined. Is there any special points to consider in your purse? Depends on your purse, Mali. I don't know what purse you got, because purse changes every year. I also noticed, because I got purse from 18 people, that purse was different. අපිට තිබ්බේ, I can't remember what purse we had now. Purse වල එන්නේ purse ticketing purse, so it's better to know, like පොඩි idea එකක් තියාගන්න නම් හොඳයි. Now that you mentioned it, let me see. Okay, so we have a question asking, a 65-year-old man with chronic renal failure is admitted with respiratory distress. He was intubated with an intravenous induction agent and a muscle relaxant. And then patient has tall T waves. The tall T waves is, and making current, you have to know tall T waves. Tall T waves is a feature of hyperkalemia. So, and patient also has chronic renal failure in the question. They have given a muscle relaxant and the induction agent. They're asking what's the drug that has caused this. Atracurium, succinylcholine, vicuronium, pancuronium, rocuronium. You know, this is succinylcholine. Succinylcholine known to cause hyperkalemia. That's why you avoid that in Burns patient, because Burns patient also can get hyperkalemia and renal failure දෙන්න හොඳ නැහැ, because they also get hyperkalemia. It's succinylcholine. Remember that. Succinylcholine was avoided in ඒක තමයි pearl එක. Avoided in high risk patient in like CKD and Burns. Yeah. Then මොනවාද? True or false? A 35-year-old patient was diagnosed with schizophrenia, was started on risperidone monthly injection. Risperidone is antipsychotic. Following few weeks of the treatment, patient was complaining slowness in movements. So, Mali, antipsychotics. I think your Parkinson lecture had this. There are drugs causing Parkinson's. The drugs causing Parkinson's, they're called drug-induced Parkinson's. So, risperidone, antipsychotic, metoclopramide, prochlorpromazine, there are a list of drugs causing drug-induced Parkinson's. I think that risperidone dunna, now he's giving slowness in movement and hemorrhagidity and all. Now they are asking, what are the essential management steps? Can someone tell me what's the drug of choice in drug-induced Parkinson's? You don't give levodopa, pramipexole in drug-induced Parkinson's. Yes, you give benzexole, anticholinergic. Nice. So the question they have asked is true, false. What are the essential steps? Add levodopa, so that's false. Stop risperidone. Well, yeah, you can take that as true, because that's the drug causing it, but ඉතින් psychotic එක ප්‍රශ්නය schizophrenia is a bigger problem. එතකොට you might consider a different drug. At Bensexol, again that's true. Arrange a PET scan බොරු වැඩක්. Reassure and continue. ඉතින් මෙහෙම patient getting side effects, you can't just reassure. Yeah, so Pearlie's drug-induced Parkinsonism cannot be treated with dopamine agonists. And then there's a question asking about hip replacement එකට ගියා. After the surgery, patient was taken but not breathing. Ward එකට ආවම not breathing ලු. Cardiovascular parameters are normal. Patient had no breathing movements. The question is not completed, but they are talking about opioid poisoning. So they are asking the antidote. Naloxone, we already discussed it. The hip replacement area must have given painkillers. Then there's another question about lignocaine toxicity. That also we discussed. SJS cannot question that also we discussed. Yeah, that's all the neurology pearls we got. ඕගලන්ටත් neurology pearls තියෙනවා නම් ඒටි පොඩ බලන්න. Those pearls for a reason. Just get the pearl out of that. No one told me. This is not a thing for you to remember, but is there any drugs that you can give even after you get anaphylaxis? Yeah. It's I'm going to tell the answer. It's antivenom. Antivenom dunnata passe you very likely to get anaphylaxis because it's made from horse serum. If you give horse serum to a person, you can get anaphylaxis. So I hope that you know that it's made from horse serum. Inject the snake poison into a horse and you make the horse die, and he makes the immunoglobulin, of course, and you purify and give. So you get anaphylaxis. But when you get anaphylaxis for antivenom, what they do is, of course, you stop the drug and you manage the patient with IM adrenaline or IV. Actually, IM will the subcut adrenaline. There's a whole other problem because of coagulopathy. And then you give IV hydrocortisone, all that. You send them to ICU, and in the ICU, you continue the drug. Because you have to give the whole antivenom until it finishes. That's the only drug that I know. Even after anaphylaxis, you don't stop it, you give it. You stop for the time being, but then you continue. It's a weird thing. Probably you will learn later. IPD what snakes can you give antivenom to? What can't you give? Because that's also OSPE. There's one snake that they commonly ask, that one that you can't give. Yes, nice. Yes, you can't give it for hump nose swipe. Remember that. Hump nose viper you can't give antivenom. For Russell, Source Scale, all the crates, and Cobra you give antivenom. Do you know why hump nose? Then there is a funny reason. Stop the record.